Waiting until your car breaks down before you service it doesn't really make sense. So when it comes to your health, why do we wait until we're sick before taking action? And when we do eventually visit the doctor or the clinic to deal with whatever disease or ailment we have, why are we content to simply manage the symptoms instead of dealing with the root cause? Functional medicine, precision medicine, bioregulatory medicine, these are names given to a specific approach to healthcare, where instead of just waiting to treat the sick, we're encouraged to look into our own lives to identify the things that might lead to problems not just now, but in the future as well, and to hopefully prevent many of these diseases and dysfunctions from ever happening. Not only that, functional medicine holds the potential to improve your general quality of life, by helping you to enhance your well-being, improve your physical and mental performance, and to help you generally feel better. It is easy to confuse this functional approach to health with other types of holistic or alternative medicine that may not have much supporting data. And unfortunately, that means that sometimes we're hesitant to put our faith in something we don't really understand, or that isn't well advertised or advocated by other members of the medical fraternity. But functional medicine is well established as an evidence-based and scientific practice. And when you actually stop to think about it, does it not make sense to try and be as healthy as you possibly can, even if that means doing some extra testing and booking a chat with your doctor to talk about some of the options when you might not have a particular disease to test for yet? Most car manufacturers will recommend regular service intervals for their vehicles, depending on the time elapsed or the mileage driven, to try to avoid any problems or breakdowns and to maximise performance. Dr.Sam van Eeden explains in today's podcast why he recommends that we should start taking a similar approach with our health. And he walks me through the concepts and the practicalities of functional medicine and modern healthcare. I'll include some of the links and references mentioned in this podcast in the show notes, and you can find these over on www.humanregenerationproject.com under episode 6. Enjoy the show. This is a podcast about finding answers to human questions, taking control, and feeling good. This is the Human Regeneration Project. Okay, welcome back to the podcast. I'm here with Dr. Sam van Eeden again. Thanks, Dr. Sam, for joining me again on the podcast.
Welcome, Dan. Looking forward.
Good. So we were discussing there before we came on air. You had some very, very good insights on functional medicine, and I know from watching you deal with your clients that sometimes the discussion with a client about functional medicine and regenerative medicine is not a difficult one, but an interesting one, because many people hear the word functional medicine or regenerative medicine and they think homeopathy, or they think acupuncture, or they think boohoo or voodoo medicine, or they think you made a funny comment there, how many oil drops do I have to take, or onions do I have to rub on my head, and this is not necessarily to dump on homeopathic medicine, but functional and regenerative medicine, it's not that vein of treatment or medicine. What exactly from your, I mean, you're a classically trained doctor, if you want to call it that as well. And what comes to your mind when you hear the word functional or regenerative medicine?
So I think the important thing is to clarify that all of these paramedical services, including acupuncture, etc., has a place in the bigger picture, and I do think that there is value added to people's wellness, even if it's just to motivate them to have a better lifestyle option. But I suppose the most important thing for us to understand, and from my patient's point of view, is that functional medicine is a science-based medicine. So this is something that has publications, that the advice that we give would be within the guidelines of safe treatment. Number one, always safety first, and secondly, would not be really an adjunctive or a type of medicine that is seen as alternative. And the word alternative has been abused, unfortunately, in many ways within the field of medicine. And if I say to you, well, I'm using Augmentin as my antibiotic of choice for a sore throat and a severe tonsillitis, alternatively, I can use erythromycin, Did I break down on the value of erythromycin? Not at all. So it is an additional option. And that's how we should mean when we use alternative. But unfortunately, in the layman's way, it's often seen as something that is less potent or less effective. So I want to make sure that our listeners do understand that the word alternative is hugely abused in this environment. And I think what I would rather say is that functional medicine, the way we understand it in modern times, is rather seen as an additional to treatment option. In other words, I don't discard the GP prescription or the specialist prescription. I've been in GP practice myself for over 30 years, so I'm fully aware of treatment guidelines and protocols, and I encourage my clients to keep on doing exactly what the doctor has advised them. In addition to this, I advise them from the field of functional medicine. That is a study of the external factors like ultraviolet light, smoking, chemical exposure, etc., on the immune system, on our regenerative system, on our ability to sustain a healthy life, and is affecting, obviously, the way our body reacts to our environment. So the study of functional medicine hugely focuses on the ability of our body to adapt to the environment in a way that makes it safer for us to have a good, sustainable quality of life. So it is not something new. In the States, the field of functional medicine is already regulated and controlled. There is an institute that controls this, where doctors can also attend further training, etc. On the continent, it is at least 60, 70 years old, mainly practiced in countries like Switzerland and Germany, and mainly was originally just used within the context of the health clinics, the longevity clinics, the health extension clinics, and these health farms where people would pay huge money and go in once a year and have their detox and all kind of. Now, the beauty of that is that science is now widely shared within the community of functional medicine practitioners, including myself. So it is mainly forward-thinking developed countries where you would find this. And what is very importantly, that in Germany and Switzerland, they don't call it functional medicine. It's known as bioregulatory medicine.
Really?
Which is
That's
even more specific to the functionality. Yeah. Bioregulatory. In other words, how do I regulate my biome, my whole body?
Yeah.
And there's a very good part of the description that actually focuses on the function of the body. So let me put it in this way. When a doctor is trained, the first year of training would be typically in anatomy. What the body looks like, the muscles, the endocrine system, the heart, the genitourinary system, the brain, etc. We look at the body and we dissect it and we learn. In the second year of your doctor training, we are focusing more on physiology. In other words, how does the system interact with each other? How do the organs relate to each other? How does the endocrine system interact with the vascular system or the nervous system? And how does the brain function to actually make this muscle move when it sends the signal down to the muscle or to the fingertip? So all of these functional systems are very well studied and very well documented, and we have a pretty good idea how the body looks and how it works. But then from the third year of your training in medicine, you go into what it's called the clinical years. And suddenly this young student's mind is completely turned around and start focusing on disease and disease management. And the first 2 years of anatomy and physiology becomes actually just like a bystanding subjects that you need to understand disease and disease management. But your whole orientation then is towards disease and disease management and how to make people better when they're sick. So no wonder by the time our general practitioners qualify highly specialized in their field of disease and disease management, it is quite a shock for any GP when a client walks in and say, now what do you think about my microbiome and eating lettuce only?
Yeah.
It is not in our mindset to think about healthy people, healthy diets. It's really not our orientation as professionals to really advise people. And hence, you would nearly immediately, by 99% of doctors say, you know what, I'll refer you to a dietitian. They can talk to you about that.
Yeah.
So the next thing the patient says, but I feel this affects my liver. You told me just I have high cholesterol. And the dietitian will give me a high cholesterol, low cholesterol diet. But what can you tell me more? What can I do to make my cholesterol disease better? And again, we are caught in this whole system of guideline treatments. And rightfully so, the GP would advise the latest guideline for treating high cholesterol disease. And I think in the end, when we look back at that approach, we basically, as general practitioners and as specialists, start managing a patient only once they present with disease.
Yeah.
So if you think about the concept today in modern medicine, it is a reactive model and not a proactive model. Now, in real life, in my own practice, how many times did someone come to me and say, I have a very sore throat. I look in the throat, I diagnose acute tonsillitis, and then say, I'm going to put you on the guideline treatment for an antibiotic, an anti-inflammatory perhaps, and also a painkiller. And the client would turn around and say, you know what, thank you. I'm reassured now. I'm sit this out. I'm going to sit this out. I'm not going to take anything.
Yeah.
I'm happy. I'm not dying. Thank you for clearing that for me. But I refuse to take chemicals. And this is a problem.
This is a really interesting point. I remember reading something, I think probably 10 years ago. It might be in the book Freakonomics. And they were talking about why doctors and I think lawyers and people like that had such a standing in society and such power over people in society. And they called it an information imbalance. And they said that obviously doctors had a huge amount of information and the client or the patient generally had nothing. So there was massive panic. This is my health. I'm worried. I'm going to get sick. Tell me what to do. Whereas nowadays, it's not to say that the doctor still doesn't have a huge amount of information, but the client also has a huge amount of information. And at the start, when we said some people don't really understand functional medicine, I think when you explain what it is to people, very quickly they realize that, hold on, I've seen this before, because there's Netflix documentaries and they speak about the importance of eating well and not taking too many medications. There's this fitness buzz now the last 5 or 6 years where people are aware of how much they can improve their health with exercise and being healthier in general. And that's a part of functional medicine, I suppose. Yeah. And when they come and see someone like yourself, a regenerative or functional medicine practitioner, it's just another level of the same concept. There are more treatments available, but you're still looking at it from the point of view of this person is sick. There's been some external stimulus, as you've said. I always say we're dying from the minute that we're born because the world takes its toll on the body. I mean, metabolism takes its toll on the body. So there are external factors causing you to degenerate or break down or get sick. And functional medicine is just a way of, number one, identifying those factors. And I think that's the biggest thing that a lot of people miss out on, is you have to identify what's going on in you. And I know we touched on this with Owen Lacey in the last podcast as well. Every person has an individual factor. So that's step one, what's going on in you. Yeah. But then functional medicine is about taking those factors and finding a way to counteract them or to prevent them or to diminish the effects.
Absolutely.
I think that's what we're talking about.
Just on that point, and I'm going to focus a little bit more on the actual definition then of functional medicine or bioregulatory medicine. And this is an important point to realize that medicine and health is a science and is constantly progressing and constantly prove new concepts correct and constantly proven older concepts wrong. And I think this is a challenge for the doctor and the client to always find that balance in what is now the latest. And I think that is why continuous medical education is so important for doctors to constantly stay up to date with changing trends, because what was believed now, for instance, on statins and how valuable they were in the past for regulating cardiovascular disease. I'm sure you might be aware, and our readers are aware, that it has now been proven that statins actually has no link to actual cardiovascular disease.
Can we touch on that for 2 seconds? Because we've had this conversation probably 20 times over the last 10 years, I say. The last time we spoke, you mentioned to me this study by the World Health Organization. And as far as I know, it's a correlatory study between the time when statins were introduced and there has been a decrease.
Absolutely.
Is it in cardiac surgery?
Cardiac surgeries.
Cardiac surgeries, okay. Yeah. So with this new information that you just mentioned there now, can you talk about those 2 points there? What has changed?
So I suppose the evidence has changed and collecting data, and that's why this is so difficult to introduce new concepts or new medicines. Because although you might have small studies, that's not always multi-centered, you have only a low-level evidence. In other words, evidence we actually measure in level 1, 2, 3, and 4. And sometimes studies are just subjective. And sometimes if they are level 1, they are very well researched, large groups, etc., and multi-centered over many different clinics in different centers of excellence. The problem is that it is not until you have the bigger picture, and I've collected literally tens of thousands of case studies, and then starting to compare the data, that the underlying trends or value of a treatment protocol or guideline is only starting to show its head. So I'm not saying that the statins have no value. I'm not saying that, and that's not what the publication says. It directly links our understanding in the past that if we give a person statins, we can reassure him that he's not going to get a heart disease or a heart attack anymore, or it has been hugely reduced. That is incorrect.
That's incorrect now.
That is incorrect.
Okay.
And the studies have shown that that assumption we made is incorrect. But what it boils down to in the end is that people are resisting and becoming more and more resistant to using chemicals and pharma products to solve their issues, and including their chronic diseases. All right. So if we understand the word functional medicine or bioregulatory medicine, it is actually about discovering the root cause of disease. In other words, going back, not managing the disease and in the long run keep people then on disease management. How about we start looking back at where does that come from? Why is this happening? And how can we change that?
And just before you get into that, just a question on that point there. Do you think this is a considered effort to keep people, we'll call it on disease management, but it's keeping people sick for the sake of selling them medication? I'm not trying to get into any conspiracy theories here, but do you think that there should be a bigger effort to help people improve in a quote-unquote functional or natural way? Yeah. And do you think that's being resisted because it's profitable to have sick people? It's profitable to have people taking medication. If you're not sick, you're not going to take medication.
Well, I don't want us to fall into the trap of a conspiracy theory, but if you're just looking at the bigger picture here, right? If you just look at the insurance companies, and their security is, as long as people are ill, they get their monthly installments of pay. Now, if you start suddenly cure people and you lose that industry, is not going to be very happy. So in the real world, where you can see that applied, is that companies are quite happy to pay for your disease, cut out the melanoma, treat the cancer that's now already taken into it. But they're not very willing to invest or pay for treatments that's preempting these diseases or possibly preventing these diseases. So prevention or preventative medicine is not a word that is often found in the insurance company and a health insurance company. As a matter of fact, if you want to do preventative medicine, it is for your own pocket. And that is worrying, not only to me or doctors like me, it is worrying to my whole industry. It is worrying, for instance, the US government, right, which is putting a huge effort into see how can we change this management of crisis control, because the fact is not even governments can afford crisis control anymore. Our own government in Ireland can't afford this anymore, can't be sustained at the level that people are spending money once they get diagnosed with a chronic disease. Why don't we use that money and spend it on preventing the diseases? That doesn't happen. There's no money to be made in that. You can't patent a recipe or concepts or healthy advice. How do you patent healthy advice and then try to sell it on to insurance companies? So I think there need to be a high level thinking about this. And let me just go back to your point that you said, is this conspiracy theory? I think let's be realistic and look at this. Let's think about the Bell's curve, all right? And the way health in general is managed, and being in the industry for decades now, I think I can reflect back on my own experience working in different countries under different health management systems and different government department of health. And looking at just across the board to the NHS and to a lesser extent to the US. I think if you look at the Bell's curve, the small part in the beginning of the Bell's curve, the rising part, that is the health policies of governments, all right? They would have a basic guideline that will say, okay, we're going to spend this much money on orthopedic prosthesis this year. They have a budget. And they basically allocate money to what they think the management of that country would be, including, for instance, vaccinations and inoculation campaigns, etc. So that's the bigger picture, but that's the smaller part of decision making. The bigger part of decision making lies with the big bell of the Bell's curve, and that's with the general practitioner. What policies do they follow? Of course, they have to take into account the first part of the Bell's curve, and that is the advice and guidelines by government and health policies which they need to implement to help to manage these millions of people living in that country. So there need to be some hierarchy in decision making here. But the GP in the end, working within that field, is very restricted to actually be able to see 30, 40 patients every day, do not have the time to individualize problems, or now to go back and say, oh yeah, you've got diabetes now, but you know what, I'm going to give you a treatment, but I'm also going to spend time now on to see where does it come from? Why did it happen? What's the genetics? What's the epigenetics about this? Listen, no GP has the time to do that. And anyway, you're not paid to do rest than just diagnose disease and manage it. That's it. It's not that the doctors don't want to look outside of the field of disease and disease management, but they within that Bell's curve, and that is their allocated duty to make sure that the nation gets health management and disease management. On the end of the Bell's curve, you would find the specialists group, including functional or bioregulatory group. Those are the people that has special training or knowledge or skill or experience through decades of exposure within general practice that says, hang on a minute, I'm quite happy to work with healthy people. There's a huge amount of people out there in the communities that says, you know what, I'm not going to wait until I have diabetes. My dad and my granddad has diabetes. I am being told since I was in my teens that one day you might have diabetes. I'm not going to wait until my GP one day tells me, you've now diabetes, here's your insulin. That group of people falls right into the remit of the patient that falls into that bioregulatory medicine or functional medicine part within the Bell's curve. So that is my kind of patients. It is the healthy patients. It's the person that's already been to the GP, has been given the guideline treatments. I have no intention of just changing that. Absolutely not. I'm in addition to the GP's advice and treatment, want to guide this person, say, listen, how can we slow down the development of this diabetes or cardiovascular disease or lung disease or whatever metabolic disease has now already been diagnosed? How do we turn that around? The GP doesn't have the time or the knowledge, perhaps, how to turn that around, given you more than just the guideline treatment, which is 100% correct. And at the same time, the government has no interest, and the insurance companies, which is in the first part of the bell curve, has absolutely no interest on the individual to focus on the root cause.
Yeah.
All right. So what we have here is a bigger picture, and that's what you asked me, and that's what I'm trying to explain to you. In the end, it's the individual that has to make the call. A lot of people are just happy to know I'm following government guidelines. I'm following the guideline of my GP. That's fine. I am accepting now I have diabetes and I'm just taking my tablets and shut up and there we go. And that's nothing wrong with that, right? But you have a lot of individuals that has not been diagnosed that actually know that they're on the way to a chronic disease diagnosis that says, hey, hang on, where do I fit in here? The government is not going to help me. My health insurance will definitely not pay for me to go to a health farm in Switzerland to get the right advice. My GP says to me, go and see the dietitian or go and exercise more or just eat right. All right. And here I'm ending up waiting another 10 years further and I'm diagnosed eventually with the diabetes, which I knew I'm going to get.
Yeah. Yeah, there's 2 points I want to pick up now. One is very, very important, I think, because sometimes it can sound when we have these discussions like we're being judgmental or a little bit facetious when we talk about other GPs or conventional medicine, and particularly relevant in your case because you were a GP as well.
Yeah.
You weren't always a functional medicine doctor. And we know that most people in the healthcare profession, doctors and nurses and physios and all that, they get into it because they want to help people. So they are good people that become victims of the system, I think. So we know that the doctor wants to help his patients, but you just mentioned he might have 40 patients in a day. How can he sit down with 40 patients and give each one an individualized nutrition plan or do specific blood markers for there are barely any labs here that will do all the blood markers. Like, so I know a lot of doctors are caught up. Yeah, there is the argument that if you really want to help people, you can go like you did and do your research and do your study and train and you can adapt your practice, but not everybody can do it.
No.
So it is an important point to make. We're not trying to cast judgment on people. And that leads me then to the second point in that, well, if the system is the problem, how do we change this? And if you have somebody who wants to, they understand that functional medicine is an option for them, they mightn't have the money. They're going to have to fund this themselves because it's not insurance backed or government backed. How do those people cope? I think I asked Owen the same question, actually, I think that in the last podcast as well. Like, where do you think this needs to come from? Does it need to come from the HSE or the NHS or in the US to help? And it's not at the moment. I think it has to start from the bottom. And I think he mentioned the same thing as the individual needs to start to make a decision to make small changes. And a little, because I mean, now we have the internet and we have people like yourselves and we have podcasts like this and we have resources. Make the small change to the diet or a little bit more exercise. And eventually enough people, I think, will start to demand a higher level of care. And that's where change will have to come from, I think, is from the bottom up.
This is the exciting part, Dan, because there is not a better example than cannabis.
Yeah, perfect.
To show you that regulation and health management and policy does not always necessarily start on government level working downwards.
Yeah.
With cannabis, it is the end user, the general public, that started the demand and the pressure eventually on the healthcare provider. And eventually the healthcare provider had to put the pressure on governments. And guess what? There's policy. Canada, a wonderful example. My son is practicing in Canada. They can prescribe cannabis. They go on a full course. They have to get permission to do this. The government make sure that you're in line with regulations and good policy, right? And now you have access in a country like Canada. But that's a very good example of people coming from bottom up and forcing their hand into governments. This will happen with functional medicine. In the US, interesting enough, because functional medicine is now active and alive and running there for the last 40, 50 years, it's actually some of the states are already employing functional medicine policies. So they're forcing the insurance companies to take on people. For instance, if you have a membership of a specific health insurance company, you actually get a reduced rate for a health farm or a gym, a local gym. So they have a huge network of gym operators that belong to the scheme. So not only do you get it, but every time you clock in for your gym exercises, you get a credit point, like a loyalty scheme.
Yeah.
So guess what? At the end of the year, the insurance companies are willing to award you a lower insurance rate because you attended 60% of your goal set by the insurance company. What do they get from that? You're going to stay healthy longer and less risk for them to start paying out on your behalf. So those plans are well in function at the moment. Not to mention names really, but I suppose a good example that crossed my mind is Discovery Health in South Africa, and I know they're in other countries as well. They have exactly that model. It's purely functional medicine based, basically, where it encourages people to change their diet, lifestyle, exercise, and stay out of the doctor's office.
Yeah.
And they award it in money by that. Now, I can't say anything more than I think that is a great model that should be considered by more than one country.
Well, it's an incentive-based model.
It's an incentive-based model.
I saw a funny one there in Russia as well. Maybe it's a less conventional one. At the train stations, they had like almost looked like an ATM machine or the ticket machine where you go get your ticket, and you didn't pay for your ticket. It asked you for 20 squats or 20 jumping jacks or something like that. So again, and it's do something healthy to get a bit of a reward there.
Great idea. Yeah.
From we've talked about kind of the concept now of functional medicine, but if someone comes in here with whatever, I mean, all sorts of people walk in the door here, but if they come into you with some sort of ailment or complaint, what's the process for them? Because people always ask, like, okay, this is great, functional medicine sounds for me. Where do I find how do I go through the process? What are the steps now for functional medicine?
I think for our listeners and for that person comes in to orientate themselves even before they see me, I think it is very important to understand the concept of bioregulatory or functional medicine. And it is really about discovering the root cause of the disease and take into account the entire person from a genetic, epigenetic, metabolic, energetic, and emotional point of view. So while patients might have the same disease or prognosis, the manifestation of the illness is entirely bio-individual and must be treated and prevented on an individual level. In other words, what I say, it's a bit like a boutique hotel or a boutique. So you design around the patient their particular genetic history, their epigenetics, their metabolic diseases, their mental status, any issues or diagnoses already made. I think taking that into account, in other words, we go far more than just the general concept of a consultation. And the process really involves, number one, getting an understanding of those points that I've just mentioned there. So we individually assess the metabolic status, the energy, the mental status. It is very important that we also measure this. All right, so we usually would have some forms that can be completed, like for testosterone, there's the Adams score, etc. There are different scores that we use, scientific scores that we use to assess people and to actually classify or give them a point system, basically, where we can see, right, this is where you're now a baseline. Where are we 3 months from now, 6 months from a year from now? It's important that we keep on by being scientific about the approach. So the first step would be usually coming into the clinic. I would have an introduction with a history taking and a blood test on the desk. And the blood test is quite comprehensive, including the general markers that we do, full blood count, etc. We do a C-reactive protein, which is basically chronic disease or cancer screen in many ways. We would do liver functions. But then we're going to a little bit level deeper. We do the uric acids, we do bone profile, we do the advanced liver functions. We do that. Endocrine system is a huge part of how we function. Remember, we in our specialty focus on that first 2 years of your training, anatomy and physiology. So we are focusing hugely on what can we identify is going wrong, how this work and system is actually performing. So we look at the endocrine system, including the testosterone, the dehydrogenase epistemoandrostenedione test. We do the FSH and the LH. We do the progesterone. We do pregnenolone where it's indicated. We do growth factors where indicated. We do the estrogen, obviously, thyroid function, T4, T3, TSH. We're doing your vitamin basics, the vitamin C, the folic acid, etc. So it's quite an extensive blood test and profile and
this
a panel.
Is not a normal GP blood test.
No, that is not. So this is going beyond the level of just basic health screen, right? And people would ask me, say, would I have this done in a clinic doing a yearly health screen? Is this similar? Yes, it is possibly similar to that in many ways. And I'm not trying to play down on the value of health screening, right? And I think it's extremely important, and I would encourage my clients to continue their healthy their yearly health screening. Continue that, absolutely. But at the same time, what those health screens do not do, and it's because it's a screening test, it observes for current disease. Now, here we're back to the whole thing of disease and disease management, and a lot of those health screens are designed to pick up something that you might already been suffering from.
Yeah.
We are in a field of how can we prevent anyone in the future picking up that you have this particular disease.
Yeah.
It's a different concept, it's a different mindset. So yes, we are focusing more on not what is going wrong in your system, but so much how healthy and how optimal is this system working of yours for your age and for your gender.
Yeah.
And we have markers where we have an idea of what it should be like. So we have a range. So let me immediately put you on that point to say, when we do the general history taking on the day, I'm obviously trying to identify already where are my future problems. Is it metabolic disease? Is it diabetes? Is it cardiovascular disease, cholesterol, whatever? And then I focus and redesign my blood panel according to that possible risk. Because we have now a much better understanding of genetic diseases, and I have to adapt my panel to make sure that I go beyond the normal to check how healthy is the system working, right? And this is exactly where we pick up on things going wrong very early, long before the diagnosis is actually clinically made or even made with a special investigation. There are indicators in our body that points to disease and disease development. We're in the business of preventing that. We're in the business of preventing a diagnosis being made.
I don't remember the exact source that he used, but I know Owen said something last week I really, really liked, and it was the absence of disease does not indicate the presence of health.
Exactly.
I think that kind of ties that up nicely. And are these tests, are they gender specific? Is it the same for men and women? Is the process same for men and women when they come in? Because I know obviously there are different considerations, but when you're talking about overall general health and wellness, is the process the same, or are there things you have to think about differently for men and women? And not just men and women, but also older people and younger people and people of different backgrounds and genomes and things like that.
Interesting enough, Dan, there's not much of a difference in the approach. It is exactly the same model we apply.
Politically now, to be very careful what you say. There's no differences between men and women.
So the only difference really is that in the endocrine and hormonal systems, we are very different, men and women.
Yeah.
But guess what? For the rest of the systems, we're pretty much the same. So the biomarkers that we would use, the range and the widths of the ranges are different. Obviously, for every test that we do, that will be different in men and females. But at the same time, from an approach on how we manage the person coming in for a bioregulatory or functional medicine assessment is exactly the same. Again, the history leads me to design the panel, the blood panel. And according to the history, so I always urge people to come actually down with a little list on the day of the consultation, because you can't remember all the things that you wanted to ask. So come down with a little list. As you give me your history, I'm noting that, and I'm also starting to design the panel that I would think I already have in my mind by the time we are finished with the blood panel, that where are my focus points where I could possibly identify disease in the future developing, right? So the better the history and the better reflection of the results of the blood panel, the more pinpoint my diagnosis or possible diagnosis for the future can be. Children, the same. Older people, the same. Obviously, in older people, we're looking at some different markers as well. We are more focusing on carcinogen or carcinoma markers, etc. In children, we are very much focusing on metabolic markers, especially if there's a bit of overweight already in the child. We obviously will focus a bit on that. Growth hormone in children are very important as well, and things like that. So it is. There's not a blueprint for every person.
Okay.
Every person coming in gets a very special blood panel and examination.
And just a loaded question for you here. When it comes to actually acting on and making the changes in terms of health benefits and stuff like that, do you think men or women are better actually taking the step that they need to come to see you, and then taking the steps to actually change things in their lives that might need to change? I mean, you've a 30-year history with GP practice as well, so it's the same question applies. Have you noticed a difference in people, a type or a gender of person who's more willing to or more open to change or to address?
So I'm going to put on two hats.
Yeah.
I'm going to put on my general GP hat. I don't think 7% of my clients would give a bother to come in and actually focus on prevention.
They wouldn't bother, or they wouldn't?
They would not bother.
Okay.
And the reality really is that they expect you as the GP to manage their disease if they have a disease. I see them only when they are sick. I can't remember of a GP consultation or 1 or 2 a week that person come into me and say, okay, I actually, nothing wrong with me. Can you just check me over? That doesn't happen.
Yeah. Would you welcome that? Would you welcome that if it happened? Because
I'm not sure if I would welcome that. I think they're wasting my time then as a GP with my GP hat on. No, they're wasting my time. Yeah. When they come for a health checkup, a yearly health checkup, absolutely no problem doing that then, because then you have a standard, I have a guideline to them, I have a recipe that I apply for this standardized examination that I perform right from the tip to the bottom, reflexes, blood pressure, all the rest. I have a recipe to follow. Right, and they don't waste my time then. But just coming in to say, actually nothing wrong with me today, would you mind checking me over? I will have a problem with that. I will possibly say to that person, next time make a full health and just do it once a year. Yeah. Because as a GP practice, I'm following best guidelines at the moment, and that is not to just see you just for because you think you are okay. So when I put my functional medicine specialist hat on, I would love a consultation like that. I would love people just walking and say, you know what, there's nothing wrong with me now, but I have a family history of high cholesterol, and I don't want to wait until I get it. My GP tells me I'm perfect. My blood pressure and my cholesterol levels are absolutely perfect. I've just had it last week, right? But I still have a concern. Right, that's my client.
Yeah. And just to clarify for people listening as well, that first GP hat that's not what you believe should happen. That's what you think happens at the moment.
That's what happens in real life.
Because a real GP has to follow the guidelines. And if I walk into you with no high cholesterol, they technically have nothing that they can give to me within the remit of their training and their practice and guidelines and stuff like that.
It's disease and disease management orientation.
Okay.
That's how my mind as a GP works. And everyone that walks into my room has something wrong with him. Yeah. And if somebody sits down and says, nothing is wrong with me, my head goes into a spin.
Yeah.
My first question, what are you doing here? Go and see the nurse.
Do you know what it reminds me of? I remember hearing once, I can't remember what it was, there's a theory that I think it was the CIA or the FBI invented the word conspiracy theory to label people who had ideas that challenged the organization. So it challenged the status quo or whatever. So if Jess came in and Jess said, do you know what? I think they're putting something in the water, or I think there's something going on here. The FBI, I think it was the FBI or the CIA, just said, right, that's a conspiracy theorist. And immediately that person was ridiculed. They have a word for that in medicine as well, and it's hypochondriac. So if someone came in to a normal GP or said to their family member, listen, I'm not sick, but I don't want to get sick. I think I might have some underlying this or some underlying that could eventually make me sick. They're usually labelled a hypochondriac.
Well, the current healthcare approaches include disease management and costly disease management strategies. That's usually induced by governments and health, Department of Health. And it's without considering or evaluating the potential of the disease reversal or prevention of the disease. So patients with chronic conditions are actually encouraged to follow costly, lifelong medication regimens and seldom would this alternative options of treatment, including diet, lifestyle changes, be encouraged or explored. That's exactly what we're talking about. The reality is that that person that actually comes in rightfully to say, is there alternatives to my statins? Is there alternatives to my diabetes treatments? Is immediately referred out of your room.
Yeah.
You as a GP feel that that should be best managed by the dietitian or somebody else than yourself. And yet you're actually discouraging that person in many ways to feel, you know what, I'm not going to go back. I'll just take my medicine and just follow this for the rest of my life. But people are going in revolution against chemicals. It's not me that's saying that is not a conspiracy theory.
Yeah.
People in general, I have years of experience in general practice. Like I explained, people just refuse to take tablets. I mean, I have people with high blood pressure that I nearly have to threaten and get the family in to make sure that these people do take their high blood pressure tablets. And I do encourage them even now coming to me to continue their blood pressure tablets. There are some diseases where we're not going to get away from the fact that you need chemical intervention. But there are a lot to be said that a lot of unnecessary medication are given to people. Now, only yesterday, a report came out that I just quickly saw on the news there about the NHS and how doctors contribute to the whole opioid crisis in the UK. And this is something that President Trump has been absolutely hammering in the USA as well, is that what the contribution of medical practitioners to the opioid crisis. And everyone is saying opioid crisis, but what is actually done? And if you look at the model explained with the Bell's curve, that's exactly what happens. The government allows that as a policy. The GP, who's on the bigger bell of the curve, prescribes it. The small guy on the functional medicine and specialist industry like myself actually sits in a situation where you say, but I don't want to prescribe this. But then you are facing a guideline that says you should. And my patients go, I don't want to. So you have three different opinions having to manage this person. And I suppose finding the middle way here, Dan, is what this is about. Introducing a different way of thinking and managing the disease, other than just accepting disease and then continuing taking tablets for your rest of life. I want to support that person that says, you know what, I have a problem with that.
Yeah. Hi guys, today I'm chatting with Dr. Sam van Eeden about functional medicine, preventing disease and illness instead of waiting until you're sick to take action, and how a functional doctor like him approaches a client's health and well-being from a different perspective. We also touch on IV therapy and how this treatment demonstrates a functional approach to health. If you'd like to learn more about functional or regenerative medicine, you can visit Dr. Sam's clinic website at www.nuacell.com. And if you want any more information about anything we discuss on today's podcast, you can get in touch with us via email at info@humanregenerationproject.com or visit the website at www.humanregenerationproject.com. You mentioned a little bit earlier in the chat there about the statin. I just want to ask you a question on that. So the recent data shows now that statins don't actually prevent heart, or they're not actually preventing more cardiac surgeries or heart disease. Have the guidelines here changed yet to reflect that? No. So we know now, the data now shows that it's not as beneficial as we thought, or doesn't do what we thought it did, and yet you still walk into your GP tomorrow with high cholesterol or markers for heart disease, and they are going to give you a statin.
So in theory, what it actually says is that we always accepted that if you have a high LDL or low density lipoprotein level and high cholesterol levels, that you automatically have a higher incidence of or risk for heart disease, right? So that is what the study is about.
Yeah.
Right. Not necessarily.
Yeah.
Using a statin is to lower your LDL and general total cholesterol levels. And that's what the tablet does. So it is a matter of now balancing the facts here, because there are also a lot of studies that showed in people with lower LDL levels and total low cholesterol levels, the prevalence for heart disease was reduced. So you have now immediately a conflict. The poor public and a poor GP who just want to do their work will have now to wait for new guidelines.
Yeah. What do you believe? Jill mentioned to me, she said she was in speaking to another doctor, and he put it very, very well. He said that the cholesterol itself, imagine the cholesterol is like the fire truck. Cholesterol is released by your body as a response, unless obviously to certain conditions like familial hypercholesterolemia, whether it's genetic or whatever. But in general, cholesterol is released as a response to something. And what is that? Inflammation. But the statin will deal with the fire truck. So the statin will send the fire truck away, but it doesn't stop the fire. So that fire truck, the cholesterol, is there in response to something, the fire, the inflammation.
Exactly.
So I think looking at it from a different point of view, what causes the inflammation? Like what is causing this response in the body, as opposed to let's just stop the body's response, but we still have the problem.
The answer is sugar.
Sugar. Here we go.
The answer is sugar. So just to put in context, perhaps, just on the topic of cholesterol, and I don't want to focus too much on this, but in essence, we always believe that a high level of LDL and cholesterol causes plaques to form in the lining of the blood vessels of the heart, eventually starting to form atheroma plaques. The atheroma plaques, over aging, starts to calcify, forming atherosclerotic plaques, closing up the arteries, and eventually you have a stroke or a heart attack or a clot. Right, so that is a myocardial infarction or heart attack. Right. In essence, what we do understand now, that is not fully true. It is not about a high cholesterol level or high LDL level. It is the amount of inflammation in the endothelial lining of the blood vessel,
which is the inner lining of the blood vessel.
So the endothelial layer is the endothelial cells, which is just like the inner lining of every little blood vessel that you have in your body, right? So this endothelial lining is supposed to be smooth and very slippery, and I suppose cholesterol should just slide through, and that's the whole concept. But when you start inflammatory disease of the endothelial cells, they start to become rough, if I can explain it in layman's terms, and they become more irregular in their appearance. And suddenly the red blood cell and the cholesterol sees this area as an area where it can be attached. So it actually starts to attaching to this inflammatory response area within the blood vessel. And that's where it accumulates. And that's how the plaque is born and formed. Right. Yes, things like cholesterol and LDL and total cholesterol can attach to that. But here's the interesting thing. And try to put it in layman's terms, the LDL molecule is a very small molecule, right, and easily attached to an area like that. But imagine the HDL, which is often described as the good cholesterol, right? Why is it good? It acts a bit like a hoover, like a vacuum cleaner. It rolls, right, because it's large. And when it rolls over an area, like a plaque area like that forming, where a lot of these small LDL molecules are attached to, the large HDL cholesterol molecule rolls over that and literally attach the small molecules and eating it up and literally lifting it away from the area where it started to form a plaque. And that's how the HDL is cleaning up all the time. That is the actual mechanism where we see that the HDL is actually neutralizing or counteracting the effects of the LDL. So why we encourage people to have as high as possible HDL is for that reason. But the reality is also, if we look at the studies available, is that nearly all of it points to that inflammatory response. And today we know that metabolic disease, which is common in nearly all people above already the age of 40 to 45 and definitely already into your 50s. We know that the more insulin resistant you become, the higher the effects of inflammatory disease in the body, the higher amount of these little spots in your blood vessels starting to get inflamed and starting to build up plaques. No wonder that we have an issue with high cholesterol disease.
So I like to break down little kind of takeaway pieces for people when we talk about, and cholesterol is such a, everybody knows an uncle or a brother or a parent who is on a statin or has high cholesterol, and everyone knows the story. They go this, oh God, your cholesterol's high, go see your doctor. They go see their doctor, they have total high cholesterol, they say high cholesterol, they generally don't come back to you and tell you their LDL and HDL levels, they just say high cholesterol. And then they're putting a statin. So what we're actually saying is, now I know it is a lot more complex than this because there are different types of LDL and HDL, but if we keep it fairly simple, your total high cholesterol, not that it doesn't matter, but it is not the one thing that should kind of give you, oh, I have total high cholesterol. Because if you have high LDL and high HDL, you kind of have a little bit of a balance there to start off with. And really, if you think about just taking a statin to lower your cholesterol, based on what you've just said there, you're not dealing with that inflammation. And the part that we haven't even mentioned, we won't go too deep into it, is taking a statin has side effects. There are a lot of negative side effects to taking a statin. So it's not just like, oh, at least I'm doing something to bring my cholesterol down. It's about looking at the bigger picture here. Is it beneficial for me just to bring my cholesterol down and have a plethora of side effects, or should I look at what's causing this in the first place? And we mentioned sugar there, we'll get into the diet side of things now in a second, but as a takeaway for cholesterol, I think the first thing people should be aware of is, if you go and see your doctor and your cholesterol is high, do a little bit of reading. And you don't have to get really, you have to be a doctor to understand a lot of this stuff. Do a little bit of reading about what that actually means, and rather than just diving on the statins straight away, we now obviously have new information about statins. Take this piece of information home. It's more to do with just managing the cholesterol. That is not the important thing. The important thing is this an inflammation in the erythrocytes or the endothelial cells. Sorry.
So that is the point I want to make here. It is much more than just taking a tablet. People need to realize, and I'm pretty sure doctors have also realized this, but do not always have the time within general practice to sit down and explain the bigger picture here. It's about lifestyle and a healthy lifestyle. Very much more important than just the statin tablet. It's about reducing your weight to what it should be, your body mass index, right? Changing your diet, take out the sugars, the carbohydrates. That is the real picture here, is reducing inflammation and inflammatory response within the body. To reflect on the whole thing, and I just want to make something very clear here, I still would follow and advise people to follow their statins if it's prescribed by their GP. Absolutely will not change that, all right? However, we know for many years that starting to take the statins will just prevent further plaques to form. I'm not aware of studies out there that has ever proven that being on a statin for 10, 15, 20 years actually reduce or take away current plaques. What does that tell you? It is a prevention, yes, by just reducing the blood, but did it actually change the risk? Maybe in some of the studies it's shown that it reduced the risk for heart transplants, and I think that is where people get the benefit from, that it stopped or reduced further plaque formation. But what about the plaques that's already been there when you started your statin at 55? Nobody can really answer that question. And what we know from research, it actually does nothing for that already plaque in situ. So how do I change that? And again, here we get back to the interesting facts. Simple things like lecithin, like phosphatidylcholine, essential phospholipids in your diet, reduced sugar in your diet, actually are proven studies that it does reduce the plaques. And here's the interesting thing. The plaque reduction can only happen when that plaque is in uncalcified state. In other words, when it's still an atheroma or soft plaque. But once it has calcified into a hard plaque, well, I suppose you need to chisel or dynamite, right? Or a bypass surgery to get rid of that plaque. And this is why the whole concept of functional medicine is so important, right? Because functional medicine really offers the potential for achieving unprecedented levels of health restoration and financial savings. So what does that mean? If I can educate, and this is what it's boiled down to, educating the masses, which is not easy. All right. So you start with individuals, groups. Eventually, it comes down into policies of government. So hopefully, in 20, 30 years from now, we will actually see government policies forcing people to have a healthy lifestyle or lose some benefits of some kind.
Yeah.
Now, I'm saying that sounds very socialistic perhaps, but what I do say is that for the sake of better health and saving many health systems, including the Irish one, that is nearly the only long-term solution, is to rather, instead of building more hospitals and having more consultations and hospital beds, rather keep people out of the bed in the first place.
Yeah, 100%. Yeah.
That's the bottom line, you know.
You mentioned diet there, so we'll touch on diet now briefly. Think about that same mother or brother or uncle that has come back from the doctor, has their statin. What is the most common thing you hear from those people is, okay, now you have to start having less fat, less cholesterol in your diet. Now, I know, I've read a few of these studies as well, and apparently there is no link between dietary intake of cholesterol and fat and the plaque in your artery. It's just, that's not how people think that you eat a spoonful of butter and that butter goes straight into the artery. Oh, it's going to block up the artery. And you hear people coming home and, right, the doctor has told me now I can't have the butter on my bread anymore. And what about the bread? Like, it's probably the bread that's causing the issue here. Yes. And have to trim the fat off the bacon now and eat it. But like, what about the bacon itself? How is the bacon made? The bacon is highly processed. So the current recommendations, and everybody has heard this in Ireland especially now, are cut the fat out of your diet. But they mention nothing about the carbohydrate, the sugar. Now, I know we speak about this with a lot of different people. Everybody is different, so there is no one specific dietary guideline for everybody. But in general, I think it's fairly well recognised now that the inflammation is not as a result of a high fat intake. Now, there's obviously many different types of fat. We're not talking about the lards and the oils and stuff like that. We're talking about the natural fats, the avocados and the animal fats and things like that. It is fairly well acknowledged now among people like yourself and anybody who's on top of the nutrition game that it is the carbohydrate. And we don't, this isn't going to be a demonizing carbohydrate conversation here, but it's the guidelines to me when I hear, for example, a friend of mine's dad was diagnosed with high cholesterol, putting a statin, and you go into their house and it's low fat flora is the spread they put on, still eating bread, pasta, jams, sugar, all that sort of stuff, but very good because I've cut out the eggs and I've cut out the meat and I've cut out all the fat. And from my understanding and any reading I've done, that's literally the opposite of what he should be doing. Now, obviously you can delve a little bit deeper, and for that specific man, there are going to be certain things he can and can't eat. So we can't just say to him, eat a lot of fat and cut out the carbohydrates. But from your understanding, as again, you have two hats on. You were a GP and now you're in functional medicine, and I know you have your own dietary interests and practices as well. The current guidelines for diet or the influence of diet on all of these kind of chronic conditions. I mean, high cholesterol is only one, and there's thousands more, and I know diet affects pretty much all of them. What kind of weight do you put on diet as a medicinal approach, or as a preventative approach, or a functional approach?
If we go just back to the quick definition of what is functional or a bioregulatory medicine, it's the study of the effect of our external factors on our genetics and epigenetic. Right. So it just lies, the answer lies already just in the definition. So when we look at the diet and modern diets and trends, etc., I think we should lift our hats for one industry that learned more than any other industry, and that's the formal sport and performance industry. So a lot of what we discovered over the last 10, 15 years were not driven within the medical fraternity. We are very much confident and quite content with our current diet and dietary advices, which we are trained 10, 15 years ago in university, which was the same story that was basically told 30 years ago. So if you look from our dietary point of view and advice for general practitioners to patients are fairly standard, more or less the same over the last 30 years. And yet our industry within our sports people and performance athletes, if you tell them that advice, they will look at you and say, from what century are you in the past? So a lot of this are unfortunately out of date and would not be in modern terms, would be scientifically supported anymore. So I know it's still part of the guidelines. And here's the thing, in medicine, in formal medicine, concepts and policies, etc., takes at least 10 to 15, even 20 years before they really start changing. Right? So the reality is that diet and what the intake we have are absolutely crucial in not only sustaining current health, but also preventing future disease. And if you really go into the health, into the sports industry and the performance industries, and you go and look at what was their goal sets, what were the end goal for their approaches, it was always about best performance. How can I get the best out of this athlete? And if you look at that, how did they get it? They optimize the physiological systems within that athlete to produce it, unless they go with illegal drugs, etc., which nobody says they should. But in general, if you want to do it in a legal way, you could only turn to two things. One is a different type of exercise or a different type of diet. And they learned about diets. They researched. People spent huge money. The industry spent huge money on nutrition, vitamins, and suddenly we started to realize, hey guys, there's more than vitamin B than we thought. There's more than vitamin C and folic acid than we thought before. Suddenly these people starting to look at optimizing not only health but also performance. And suddenly we realize, you know what? This is like something that we forgot in a closet. And you know what? It's time we open the closet and take it out again. Because for hundreds of years, humans were quite healthy. I'm not saying they didn't get cancer. No, I'm saying they were quite healthy on their little with their little gardens in the backyard, feeding themselves, less exposure to the chemicals and the elements that we've been, and by far less exposed to carbohydrates and sugar, which is the result of the modernization and of industries. So that found their ways into our breakfasts, into our lunches, into our dinners, into our fast food industry. And if you just listened to, just 2 weeks ago, I think the stats coming out, but the fast food industry grew in the United Kingdom with 56% in the last 3 years.
Wow.
It is absolutely shocking. Because if you go and do a little bit of research, you would see that that particular industry and food types would be high in sugar content. The whole thing of how you get people to get hooked onto food, and especially on soothers, is to give you enough sugar.
Yeah.
Whether it's in a spicy cream or in a topping or whatever, you would get your good level of glucose in with every meal. Subconsciously, once that glucose has basically soothed your sweet tooth, guess what? You're already fixed. Oh, I'm going to get this again. Yeah. I'm definitely going to get this Friday again. You know, so it's a growing statistic that worries people like me, that actually worries governments genuinely and departments. And what are we going to do about it? Because at the one hand, you can't say to people, oh, you can't have a takeaway, you know, there's a law against it. You know? So it's down to education again. How do we get people to actually think differently? So coming back to your actual question on how important diet is, it is absolutely the most important thing that people can change. All right. They can't change disease always, but they can prevent and they can reduce the effect of that disease. They can also, in some cases, turn it around. Absolutely. It is possible, right? But how do they do that? It is lifestyle, good advice, education, and changing the diet. Now, if I can simplify it more or less in that recipe, when you get to that point where you're prepared to say, I'm going to change my lifestyle, I'm going to change my orientation towards myself and how I want to pan out with my health in life. Do I really see myself taking tablets every day for the rest of my life? Am I going to end up with a loss of sight because my family history of diabetes and I'm most likely going to get diabetes? And I'm going to do a bit of my exercise, but very importantly, I'm changing my diet. If you're one of those people that think that way, come and see me.
And when we talk about people who come and see me, to people who come in for a wellness or a preventative or bioregulatory consultation or treatment plan, is diet something that you include as part of a person's treatment plan? Obviously there are treatments, we'll touch on IV now in a second, but is diet one of the things that as a practitioner you will be prescribing, I suppose is the right word, for clients?
Absolutely. So in my practice, again, I don't have the time to sit down with a person and go through your breakfast, your lunchtime, etc. But I have very good links. I've got very good advice. I've got brochures. I've got advice for you to go on a diet. But I much rather refer you on to somebody like Owen Lacey or a local dietitian or person of your choice. There's a lot of people working in the industry, in fitness and performance gyms, that can give you very good advice on your diet. So all I do is I gave you the instruction, what type of diet might be most suitable for you. I will happy to give you basic information about that. And if you don't want to avail of any of those paramedical services, of course you come back to me. Me and you work it out. You just have to do your own reading and a bit of research, and there's lots of that on the internet. My experience, Dan, is that I don't have to encourage a lot of people or walk with a whip to make sure that they actually do it right. People, when they get to this point, to say, I'm changing my lifestyle. They are motivated. I must honestly tell you, I don't think any patients actually fall off any of my programs.
Wow.
Where my GP if I look at my GP practice, my goodness, sorry if I have to say that, possibly 50% would not follow what I tell them anyway, because it includes chemicals.
Yeah.
So the real world within functional medicine is that people and individuals who fall into that small group within that Bell's curve are motivated, do know that they're going to have a problem. But I want to say something about, you asked me about what is the reason, the cause of that, and I said to you, sugar. I do think there's one thing that our public is not realizing yet, and I'm sorry to say that I think a lot of my colleagues do not emphasize that even in just general practice or even specialist practice. And that's the whole issue of metabolic disease and the huge escalation of metabolic diseases. And good examples of that would be, for instance, just diabetes. So what does that entail? As we age, Dan, it's not only our skin that gets wrinkles and lines. Guess what? Your pancreas gets wrinkles and lines as well in comparison. All right. So the reality is that our body starts to degrade like the day, like you said, like the day I'm born, I'm starting to age. That's exactly what happens. But as we age, our insulin production changes as we get older. And the amount of food that I eat change in the way it's broken down and put into energy. That's the whole idea of eating, is getting energy, right, and sustain your body's function, right? So as a teenager, absolutely no problem eating 5 times a day, 5 big meals a day, and have a chipper on the way home, and as well as a nice chocolate bar. Right?
This is not medical advice, by the way.
It's not medical advice, but that's what happens in teenagers, right? You try to do that when you're 30. The same thing, the teenager tried to do that when he's 30, and I'm telling you, he will expand within a year and become huge. Right? Why is that? What changed? Pancreas function. So many other things as well, but in general, it is the way your body metabolizes glucose and carbohydrates that mainly changes. And as we get older, the insulin production gets less, the beta cells in the pancreas becomes less active, they respond slower, they produce less insulin. We call it insulin resistance or insulin depletion. And what happens, a lot of the food that you eat is actually biotransformed into energy, but rather transformed into fat stores. And suddenly, I'm getting huge. And you tell me when you sit with me in practice, oh, I'm eating the same that I'm eating 10 years ago, but I'm just expanding all the time. That's exactly what I can explain to you what's happening. So this will bring us onto another podcast, which I would love to talk about instead. How do we actually manage metabolic disease? Because we actually don't do that. We do it only once you're diagnosed. Then we jump in with all kinds of measures to improve the way your body manages its insulin. But Kate, hang on there a minute. Oh, you have to wait until you have the disease. Then I can do that. Which I'm not exactly sure how the public would feel about that, And then we're back into who's going to do that, I can't expect a general practitioner to start spending time while somebody with a real cough and somebody that's really ill is waiting outside, So it is a difficult one, but it is a personal choice. Once people have decided, I want a different approach, I want to prevent disease, it is a whole set of available services to you, and if you knock my door, I would gladly help you.
Yeah. Well, let's talk about one of those services and staying in the theme of nutrition, and that's IV therapy, which is one of the treatments you do here in the clinic. And we mentioned it briefly. We did a podcast on NAD, and we touched on IV therapy because that's an IV treatment. But just a little bit of a snapshot for people of what IV therapy is. So my understanding originally, you see a lot of these kind of Hollywood clinics over in the States. They're very, very popular, and you have your drip bars, and it's all very, very kind of high class celeb stuff, and you go in and you had a hard night party the night before, you get your IV, and it usually has a Myers cocktail, so your basic combination of vitamins and a saline bag, so you're hydrated, you get a few more vitamins, you recover from your hangover. But this is actually something that has a big place in functional medicine as well. And obviously we're just talking about nutrition. When you think about IV and vitamins and minerals, you're talking about nutrition and supporting metabolism and supporting immune function and things like that. Where does IV therapy fit in for a practice like you when you're dealing with someone who comes in and you've just spoken at length about the bigger picture view of health, preventative medicine, functional medicine? What's the point of IV therapy? What is the point of vitamins and minerals? Let's have a little chat about that. Dive into that there for a minute.
So if we look at the basic reasons why we stay in existence as human beings, even just very short after birth, you put to the breast and you have your first meal as a human being. And within that colostrum, the first mother's milk, are very important elements that will sustain your health and life as a human being further. And that pattern is called hunger, all right? And when you get hungry, there's a specific reason for your body to request certain elements that is necessary for it to sustain its own wellness. And I think for your whole life, you most likely will follow that pattern of eating 2-3 times a day, or at least once, If you're really fasting, I suppose you skip a meal. But the reality is that in general, that is a hunger center that drives the way. And interesting, there's many studies that will show what you would like to eat or what you crave to eat is exactly what your body needs for sustaining a particular health. All right. So sometimes we have a taste for steak, another time maybe for chips, and so it goes on. So our body is quite good at identifying and actually creating a crave for a particular element that is missing. The reality, however, is that in our modern times, if you think about us here in Dublin, right, I buy my food of a local grocery store, which gets it from a storage facility somewhere in Dublin or in the Midlands, right here. A lot of that comes from the UK, from cold storage in the UK. Where does it come from? From the UK ones comes from Spain. A lot of that comes from the tunnels where it's from. And if you really could trace the date on that, possibly anything between 2 days and 2 weeks after that was harvested. From that time that it was released into cold storage until it's in my fridge, right? But try to dare take that vegetable or fruit out for just 2 days from your fridge, and you have a collapsing, non-edible, really not nicely looking fruit or vegetable. Why is that? Because when you look at the whole refrigeration chain that follows, you would realize, and if you look at the research and you go into the good biochemical research into this, you will see that a lot, and especially your vitamin C, vitamin B vitamins, are all temperature sensitive. Right, so what it tells you, if you heat it up or when you cool it down, you destroy a lot of that. So what we think we eat and what we actually bodies actually do get is two different things. So in a modern Western diet, like we're in Ireland at the very bottom end of the food chain and the food supply chain, no wonder that we have a lot of diet-related diseases in Ireland. And so it would go for the rest of Europe and for all developed countries, right? Yet if you look at the patterns in underdeveloped countries like Africa, where I'm not talking about malnutrition, but I'm talking where communities actually grow their own, you have very little of these metabolic diseases developing. They're not that overweight. They sustain better lifestyle and quality of life than a lot of us can say living here in first world Dublin. So the reality is that what we eat is not always what we think we eat. Yeah. And I just want to have that one point sitting with people to understand. As a result, we are actually deficient in many things. So here is the point about vitamins. How important are vitamins, minerals, the biofactors, etc., the coenzymes, etc.? Our whole body, and I say again, go back to first year and second year training in medical school, our whole physiology depends on the supply of fuel. All right? Where's the fuel coming from? It's from our diet. What's in the diet? It is the fuel. Yeah. Right? So what is in this that is so important? That is basically our vitamins, etc. And what do they actually represent? It represents the anti-aging elements for our body to sustain health. So if you have a lack of, say, for instance, vitamin B3, you're developing a disease called pellagra. And pellagra, if you give that person vitamin B3 again, guess what? You turn it around and the person heal up again. Yeah. Right. So the reality is that we are very clear on linking a deficiency in certain vitamins with certain diseases developing or escalating in the absence of that. Over and above that diet that we get, we have one big threat, and that is the word time. With time, and as the clock ticks in everybody that's born onto this earth, there is an oxidation process taking place. In other words, your body being exposed to ultraviolet light, to chemicals, radiation, medication, radiation from ultraviolet light, being in the sun, sugar in your diet. Oxygen, yeah. Right, it starts an oxygenation process. In other words, the molecule actually loses one of its 8 electrons. That means that molecule is now called a free radical. So we have trillions of molecules in our body, yes. But gradually over time, more and more of these molecules lose the electron and becomes a free radical. And we have very clear evidence to link free radical increase with development of disease. So why is that so important? Guess what? We have a natural remedy for the free radicals. How do we cure or how do we correct the free radical? The answer lies in vitamins. Vitamins is an antioxidant. It means it is very rich in electrons. And when you eat proper vitamins or when you get it in a high dose, the electrons are released within the body. It finds those free radicals with just 7 electrons. It donates the electron onto the molecule, and now the molecule has 8 again, and you have a healthy cell. But as long as that cell has got 7 electrons, it is an unhealthy cell. It's called a dysplastic cell. And what often happens in how disease develops is actually very simple. That is when you find 2 molecules, each has just 7 electrons. And when two of these molecules come into the vicinity of each other, and they both realize, according to the chemical laws which we teach in high school, that you will always find equilibrium, they realize, you know what, if we share an electron, we both have 8. And the two electrons collide, connect, share an electron, and both now have 8, and it's now a stable molecule. But does that molecule look like the mummy? Does it look like the original blueprint? No, it doesn't. That is a dysplastic cell. That is typically the pigmentation you see developing on your skin. That is typically the diabetes starting to develop within the pancreas cells. That is typically the hepatic cancer perhaps developing, the tumor developing. It's a dysplastic cell, a dysplastic cell that becomes more and more unstable, more and more electrons are pulled into this group or this scrum of molecules, and they don't look like the original tissue at all. So when we use high doses of intravenous antioxidants, which is intravenous performance vitamins, we actually donate huge amounts of these antioxidants into the system to stabilize areas like that. So do we say we cure cancer with intravenous cocktails and treatments? Absolutely not. But do we reduce the risk? Yes. Do we reduce even the development of these cancers? Yes, we do. Right, because there's evidence that clearly shows that if you use your basic physiological methodologies, that you actually change the course of a disease.
So it's your functional medicine again. You're not waiting until someone gets sick and saying we're going to use this to cure, as you said, your cancer or your whatever it is. You're saying, if we optimize your health, if we make you the healthiest you can be, if we give you all of the ingredients to boost your metabolism, if we make your immune system function properly by IV therapy or diet or whatever it is we're using, you can actually prevent disease.
Absolutely. You can prevent disease. You might not completely stop it because you might have a very strong dominant gene for that disease and you will still develop it, right? Yeah. But what I do say, a lot of diseases like metabolic diseases can nearly eradicate it. And we know that from studies, right? So here's the thing. If you think about celebrities, people with real money, how much they prepare to pay for their health. Go to Switzerland or Germany for a health farm and stay for a week every year. What do they get? Exactly this. Yeah. Right. So this is the point. All right. We know that if we introduce regular high doses of antioxidants into the body, combine that with a very good lifestyle, exercise, and a diet that is low in carbohydrates and sugar, right? We basically can say to a person, we are busy extending your lifespan. And that's why people pay that kind of money to get access to that. How do they keep in work longer and better? How do they prevent genetic disease even or presenting in the body? So we have discarded and brushed aside the basic facts of vitamins. And let me just put my GP hat on for a second again here. Anyone walk into my clinic saying to me, you know what, I'm a bit run down, I'm a bit low in mood, I think I'm just so tired, I just can't get up in the morning for the office, blah, blah, blah. I would go, why don't you get a good bit of vitamins? If you go across the pharmacy or to one of the health shops, get a good vitamin mix. That would be my GP hat. Yeah.
Like a multivitamin you take in the morning.
Exactly.
Or whatever,
Just go in there and just get a handful, just swallow a handful in the morning. But if we really go into the science here, and this goes for intravenous as well, we know very little. And we have very little scientific support or evidence that it makes real difference. Why? Because nobody is investing in that. Vitamins can't be patented, right? So we're back into the conspiracy theory to say, why would industry and the pharma industry invest huge money in doing trials and studies on vitamins which they would get absolute no benefit from? Not financially, at the least, might get some recognition for. No interest. Private money, private investment, no chance. So no wonder that we have very little investment in real large trial studies, unless governments undertake that, In 1939, in World War, when niacin or vitamin B3 was discovered to be the reason for pellagra, the government introduced that within the food chain of the soldiers. And guess what?
They put it in the flour or something.
Yeah, in the flour, exactly. And that's a government jumping in and saying, listen, we better do something about it. And they cured thousands of people. Right now, you're not going to get that in modern time. For governments to say, okay, now from now on, we're going to prevent cancer and we're going to put that into the food chain. All right. No, it is up to the individual to relentlessly seek best advice on health.
Okay.
And this is where this is so important. Although I might have very little evidence, even in a high-level evidence, of exactly how vitamin C prevents my cancer or how vitamin B3 prevents mental illness, etc. There's actually very low evidence on that. But does it make a change? Yes. And how do we know that? Subjective or objectively, we know that make a change. But what's wrong with my GP hat? No, there's nothing wrong by saying to patients, have a good healthy diet and get additional vitamins. It's not wrong. It is the model that is the problem, right? Because what is the truth? If when you take vitamins like that, and for that matter, most oral medications, you would absorb only about 20% of the value or the vitamins that you... Why? Because our gastrointestinal tract is such an incredible barrier. It will just prevent anything that is not natural to go into your body. So you waste basically 80% of what you paid for, right? And this is exactly the reason why functional medicine is focusing on using intravenous use. So intravenous is when I put a small drip up and the vitamin goes into a bag and that goes then directly into the bloodstream. What's the difference? The difference is huge because I'm actually bypassing your gastrointestinal barrier. Now I have 100% absorption of whatever I put in that bag. And your body would absorb that vitamin to a full extent within every cell in your body. And if we talk about a treatment like NAD, nicotinamide adenosine dinucleotide, which I will have a separate podcast on, right? They are absolutely critically important for not only sustaining health, but preventing disease, correcting metabolic deficiencies, increasing energy, etc. Why? Because it's directly intravenous. Think about an anesthetic in theater, a general anesthetic. The moment I start injecting, you hardly can count to 10 when you're out like a candle.
Yeah.
This is intravenous treatment.
Okay.
Within 10 counts, those elements and antioxidants are already releasing the electrons. And that's why over decades, these treatments have been proven to be very effective in managing preventative medicine, right? So you mentioned there, a lot of clinics just do this on the fly and it's more like a fashion, and just have a drip clinics and have just a run in and out service.
Well, I think it popped up really more in the States as part of this health revolution. People were first of all starting to get fit, then they wanted to eat a little bit healthier. So it did come from a good place, I think, but it ended up being more of an Instagram kind of, here I am, a health buzz kind of a thing, rather than a functional medicine approach. Because as far as I'm aware, when you go into a lot of these places, you don't necessarily get the full package like nutritional advice or blood testing. And again, I'm no judgment on these places. Obviously, it's a beneficial thing if you're getting vitamins, no matter what way you do it. But there's more to it.
Now, reality is that I'm not slagging it, so doesn't you do not. Reality is that you would have a guy going into a clinic like that, getting a drip because it's nearly around the corner, lunchtime procedure, go and get a drip, and you sit there eating your chocolate bar. So my question is really, what are you trying to achieve here? On the one hand, the chocolate bar is full of sugar, which is absolutely free radicals in a concentrated form, and you would be exposing your body to that. You walk out there, light your cigarette, So the reality is that unless you actually do it within the context of a physician that actually knows his job and knows what anti-aging treatments are about, or optimal health or optimal performance treatments is about, you're actually just soothing yourself, and just for the fly of it, do a treatment like that. Is it bad for you? No, it's not. Right. But is it optimizing your health outcome? Absolutely not. Because unless you really change your mindset about where you're going to go with this, then just on that point, I need to make sure that the listeners and my clients really understand that is that you need to manage this yourself. It's not only making this decision yourself to do this, but hey, I'm the coach.
Yeah.
I'm telling you, this is what I think you can do. This is what you should do. This is, I think, what your outcome can be. It's a bit like you doing your coaching work within your sport. I don't want you to run this in 13 seconds anymore. I want in 11 because I believe you can. All right. So that's exactly what I do. Right. But hey, if you don't do your diet, if you don't show up, etc., I feel sorry that you missed the opportunity. Right. I'm available. I'm here, but you need to manage this.
You mentioned context there. Let me see if I can put all this in context. So I come in and I am either a sports person looking for an increased performance. I am a normal person suffering with fatigue. I think I have some metabolic disease in my family. I'm sick, whatever, one of these people. This IV treatment is not, and I've said this phrase a few times, a magic bullet treatment, but it's a very, very important part of the process. It could give me a boost. Yeah. But I also need to consider optimizing my diet, because even though I'm only going to get a certain percentage of nutrient from my diet because of the production processes and stuff you mentioned, if I have a good diet, it's the majority of what I'm going to be doing throughout the year is not having IVs, it's eating. So that's a massively important part of it. I might consider also a multivitamin if I think I need it, even though again I'm only going to get 15 to 20% from that. It could be a nice way to enhance or improve what I'm doing with my diet. And then the IV drip is a way of giving me a kind of a guaranteed boost.
Yep.
I don't necessarily need to do this for the rest of my life, but I will have to do something like this until I get to a point where I am satisfied, and maybe you're happy with my blood markers or whatever it is we're looking for, that I've hit my goal, or that at least I'm in a place now where I am well or healthier or feeling better than I was before. Is that kind of a good way of looking at it?
Here's the thing, Dan. That's exactly why I say you need to manage this.
Yeah.
Because the reality is that the time is ticking. The clock is going on and on and on. Right. Whether I get the drip treatment once a year or once a month is my decision as the client, because the reality is that we constantly age. And if you want to optimize that, yes, it is best perhaps to have it every month, but it's not always practical. It's not always financially feasible to do that. But the reality is that every treatment counts.
Okay.
Every treatment releases the antioxidants that your body constantly need, because the free radicals forms every day. That's why disease develop in the first place. All right. So when you come into my office and we do the history and we do the blood workup first, I usually would see you a week to 10 days later, and I would spend a good hour then working out and identifying, first of all, was your health profile, your disease profile, your possible diseases for the future. I identify markers in your blood that's already going wrong, and I'm also identifying what's good or bad. But in the end, we come to a point where I suggest to you, this is a treatment plan. It might involve some regenerative medicine if there's any orthopedic issues or correction of injuries, etc., where we can use stem cell-based therapies, that's the regenerative side. Or we might just go with a pure diet. Because metabolic disease plays such an incredible role, we are looking at ways of managing or preempting treatment of your metabolic disease. Weight management is a huge part of a lot of people suffering from that. And then we work out a treatment plan that is very comprehensive, very detailed. I give you the links to help, right? Just like a general practitioner would do. So you would get all the support that you would have, links to that, even referrals if you need to go and see a specialist for any of your particular endocrine problems or anything where it's appropriate. You would get a very good access to health advice, like for instance, people like Owen Lacey or other health gyms, or people focusing on health professionals on other aspects of either exercise or diet requirements. So you will walk out with a plan, all right? Typically, and I've not even touched on this today, in my male clients, remember the huge importance of testosterone deficiencies, and that is a whole podcast on its own. The reality is that nearly all males above the age of 50 should be on some form of testosterone optimization therapy. Just like females have HRT or hormone replacement therapy, males have the same issue. But guess what? Not a word is said. Not a word is promoting that issue, which is a huge elephant in the room in health today, not only in this country, worldwide. So that's a whole episode. Don't even get me started on that topic. But the reality is that when you leave, you should have a very clear understanding of possible routes to take. And I give you a treatment plan where I stipulate what type of intravenous treatments would be appropriate to you. We can have added treatment like the NAD or ketamine where it's indicated, procaine. We have different types of added on value intravenous treatments which we can add to that for particular indications. We don't just treat, we just design a treatment. And that's the big difference from just a drip bar. Yeah. Where everyone just gets more or less the same stamp. This is not how it works in functional medicine. You custom design every client according to its needs. Now, in some people and in some cases, this is also called precision medicine. And I love that word because it's actually what it is, where general practice is general advice. When we start talking about functional or bioregulation medicine, means I have to be precise per client, per need. And this is a very nice way of explaining perhaps to people what we do in the clinic is that we focus on the individual, on their particular needs, and design a protocol that fit their need.
Well, Dr. Sam, was a great little intro into functional or bioregulatory precision preventative medicine there. And again, we took the lid off many, many different topics there that we'll dive into future podcasts. But
looking forward.
Thanks very much for the time today. Thanks for the chat, and we'll see you next time.
Fantastic. Thank you very much, Dan. All the best.
Take care. See you now.
Thank you.
If you would like to learn more about anything we discussed in today's podcast, or if you want to get in touch with Dr. Sam's clinical team, you can find everything you need on www.nuacell.com, NUACELL. Or if you have any questions or would like to chat to us, you can get in touch via email at info@humanregenerationproject.com, or visit the website at www.humanregenerationproject.com. If you enjoyed the podcast, or if you think someone you know would enjoy it, please pass it along and support the show by subscribing and liking on all of your usual platforms and social media. Thanks for listening. See you all for the next one.